Next speaker is Evins from MGH, and she's speaking about community health worker support improves provision of effective treatment and smoking cessation success.
Thank you so much. I hope that you can see me now and my slides. Can you see my slides as well?
I think you have to share your screen.
Okay.
Yes.
Excellent. So I'm one of those lucky people who's been working with Dr. Cather for a couple of decades, and many of the other folks in the Center of Excellence. And they've helped me immensely in the work that led up to this trial and in the design and then the conduct of this large trial, which really we are just writing up now. So I'm delighted to be able to present the results with you today. So it's not. So this in the disclosures, the first order of business is the trial funding. This was funded by a PCORI large pragmatic trial grant. PCORI is a patient-centered outcome research institute, and they exist really to test and then to implement evidence-based treatments. And so that's what we were endeavoring to do. We also received a qualitative supplement from PCORI to understand the barriers and facilitators to implementation of the interventions that I'll share with you today. So as is no surprise, tobacco smoking remains highly prevalent in people with serious mental illness, and it is the single largest contributor to a markedly elevated mortality rate in people with serious mental illness. And this real disparity is thought to represent anywhere from 25 to 30 years of life lost. My slides are automatically advancing, but I'll try to not let that get in the way. So unlike what's often believed by primary care doctors, most people with serious mental illness who smoke say they would like to quit smoking, would like help to quit smoking. And we've spent now about 20 years showing that medications plus behavioral treatment, particularly group treatment that Dr. Cather has designed, improves abstinence rates significantly in people with serious mental illness. So it helps them to quit smoking. And both the medications and actually quitting smoking are well tolerated in people. That doesn't change the course of their illness or make them more ill in terms of their psychiatric symptoms. In fact, more recent research shows that people's symptoms get better within 6 months of quitting smoking. But we now know that evidence-based smoking cessation medications, and in particular the most effective one, varenicline, is underutilized, basically underprescribed for people with psychotic illnesses in particular. So, you know, we've worked to show that these medications work, that people want them, and we've learned that they're underprescribed. So we sought to test 2 interventions in the system to see whether they could improve provision of these medications to give people with serious mental illness sort of the quality of care that they deserve and to help them to quit. So what we tested was a form of education to primary care doctors called academic detailing, which is a process by which you go to the doctors and any of the prescribing clinicians and talk with them about what they know about a treatment, what the barriers might be to them prescribing treatment, and providing basically individualized education. So we tested whether that would improve abstinence rates, whether a community health worker support to people who smoked in the community, in their neighborhoods, or the 2 combined would improve both provision of evidence-based treatment and abstinence rates in smokers with serious mental illness who were receiving at the time CBFS services through Bay Cove Human Services or through VinFin. And our primary outcome, really what was going to have us understand whether this worked or not, is whether people's quit rates were higher at the end of 2 years than in treatment as usual. And we thought that this would work by use of medication. So that was our secondary outcome. So we identified almost 1,500 people who received CBFS services through DMH from Bacove-Vinfen, who smoked tobacco. So they didn't need to want to quit. They didn't need to ask for services. Just if they had CBFS and they smoked, we considered them eligible. And we went to meet with each of them and ask if they would participate in the study. And 78% said yes. Again, they didn't need to be ready or willing or want to try to quit smoking to enroll. We wanted to work with everybody. And then academic detailing was provided by yours truly and a number of the other clinicians on the team. So we went out to primary care sites and met with docs, or we did it by telephone. And then the CHW support was again provided in people's homes, in their neighborhoods, and in other community settings. So some numbers to sort of describe who joined our study. Again, we had 1,165 people. They were on average 47 years old, 31% were women, and half were white, 35% were Black, 4% were Asian, 7% were multi-race, and 17% identified as Hispanic. And 40% were living in some sort of group home or shared living environment. They had expired carbon monoxide in their breath, which is a measure of how much they smoke, of 23 parts per million. And that's about what a 1 pack a day smoker would tend to have. They were moderately nicotine dependent, which is what this number means. And they smoked about 3/4 of a pack a day. 83% smoked cigarettes, 33% said they smoked mini cigars, 7% smoked rollies or hand-rolled cigarettes, only 1% smoked e-cigarettes or vapes. 2/3 had been recommended by their doctor in the prior year to quit smoking, but only 1/3 had been prescribed a medication to help them quit smoking. And standard of care is that you get advice to quit, you get a prescription for medication, and you get referred to behavioral treatment, be it in a group or individual or by the quit line on the telephone. So again, here's a discrepancy that we see just right in our patients when they came into the study. Only 6% had been offered varenicline, which is the most effective treatment, while 31% were offered basically usually nicotine patch. Which by itself is not super effective, which you'll see here too. And here's what we did in sort of a cartoon drawing, essentially in terms of how people got the intervention. 1,165 people came into the study, they enrolled, and when they enrolled, we went out to meet with them and we talked with them about their smoking, et cetera, and we found out where they got their primary care. And lo and behold, a little over 1,000 of them were treated in 75 clinics where there are at least 3 participants that came in the trial. And so we could go out and try to provide education to those doctors. But in an illustration of how dispersed our care is in the United States and Massachusetts, 111 people came in, and 155 people came in who were treated at 111 clinics. So basically 1 person per clinic. And so we did not provide education to those physicians. We assigned those participants to get a community health worker or be offered a community health worker or not. TAU is treatment as usual. In the larger cohort that was eligible for detailing to their doctors, we randomized the clinics first, 2/3 to 1/3, to provide detailing to their doctors. And then amongst those whose doctors got detailing, people were randomized to either be offered a community health worker or not. So not a simple study. And here's a bit about the intervention and how many people got it. So community health workers, these were people who were bachelor's level trained. They had never had any clinical training. We trained them, provided about 2 weeks of training. And their job was to go out and meet with participants who consented to meet with them and to support the goal of smoking cessation as people wanted it. And many people wouldn't even talk about their smoking. And in those cases, the CHWs basically tried to build a relationship and to be helpful to folks, whether it was helping them get to another medical appointment, helping them address another sort of cardiovascular risk factor like weight loss or getting some exercise. And in the end, 2/3 of people who were offered a CHW accepted that, the support. And those who did accept the support had about 20 visits with their community health worker over the course of just under about 1.5 years, over 15 months. And if you had a CHW, you were also eligible to attend smoking cessation groups. And nearly half of those who consented to having CHW support went to one of our smoking cessation groups, which were designed, and a lot of them even led by Dr. Cather. So like I said, the CHWs emphasize building trusting relationships and really knowledge of the participant's home and their community, so that if the participant wanted help to quit smoking, these people were in a really strong position to offer tailored, really personalized behavioral support for helping them to quit. Now, detailing, again, was education to the doctors, and their goal was to really focus on the importance, the safety, and the efficacy of offering evidence-based medications for smoking cessation to all smokers with serious mental illness. And these detailers really sought to implement a new treatment guideline, which was out there, which was to offer smoking cessation medications to all smokers using what we call an opt-out approach. So everybody gets offered cessation medication, and if they say no thank you, well, obviously that's their choice, but you really offer it because you want all people to take the medication, because taking the medication can reduce craving and improve people's sense that they could be successful in quitting. Now, we were able to get to 30% or 33%, or about 1/3 of the targeted primary care doctors, which meant that we got to nearly half of the doctors of participants in the study who were eligible for detailing. And what we found was not what we expected. We expected the detailing to the doctors to be effective, and even more effective when it was combined with the community health worker support. And what we found was that the community health worker support improved odds of abstinence. Sorry, there's an automatic thing advancing my slides for some reason. So the CHW support improved abstinence rates by 70%. And the detailing to the doctors didn't increase abstinence, whether it was given alone or together with community health worker support, right? And how did this happen? Well, it seems that the community health worker increased the odds of getting any cessation medication, so by 85%, and it tripled the odds of getting varenicline, right? And I'll show you in a moment that provision of varenicline significantly improved abstinence rates, but if you just got any cessation medication, it didn't significantly increase abstinence rates. So, and then finally, in a sort of an exploratory analysis, we find that the CHW, not only did it increase the medications getting out there and probably patients taking the medication, it improved the efficacy or the effectiveness of the medication. So here are the tables. So these are just the observed abstinence rates in the different arms. People who were in the larger arm that was eligible for detailing, about 7% quit smoking if they had treatment as usual, and about 8% of them quit if their doctor got detailing. So not much effect there, whereas there was an effect of adding the CHW. And then in the ineligible arm, the people who were at the small clinics where they didn't get detailing, adding a CHW increased abstinence rates by 5%. So we did what's called a mediation analysis to understand what's the impact of the CHW intervention on medication and the medication on abstinence. And then what's any effect of the CHW intervention on abstinence that wasn't through this mechanism of medication. So here's what we see is adding the CHW did, on the borderline, increased odds of abstinence independently of medication. But the meat of the intervention is significantly increased provision of medication. But again, any medication use, it increased abstinence a bit, but not what we would call significantly increased abstinence. And then the same cartoon or graph, if you just look at varenicline use, we see the direct effect of the CHW on abstinence. Again, it's positive, but it's not significant here. So the bulk of the effect went through this medication. So having a CHW tripled the odds of getting varenicline, and then getting varenicline increased by almost 90% the odds of quitting. So this seems to be really where the action was, that all the different things the CHWs did to improve trust and to work with participants, to establish a relationship with participants, really came down to helping them identify smoking cessation as a goal, go to their doctor, communicate with their doctor, get a prescription for varenicline, probably go to groups, and figure out ways to remember to take their medication, to work out any side effects, overcome them, stay on it, and quit. And so this last analysis gave us this intriguing finding that yes, varenicline use significantly increased abstinence, but that about 36% of this effect was via the CHW, independent of the medicine. And so we flipped our analysis to look at it by medication use in those who did not have a CHW and medication use in those who did have a CHW, just to sort of unpack things. And what we see is that fewer people with a CHW got no meds, okay? And then more people with the CHW got varenicline, so 5% versus 10, or got both. So 6% versus 16% or 17%. So clearly they're getting more varenicline if they had a CHW, but also getting the medication alone, so getting the medication without a CHW did not confer increased abstinence rates, but getting the medication in the context of CHW significantly increased abstinence rates, right? So whether that's through taking the medication more or getting more behavioral support, or we have this supplemental. We've been interviewing participants, the CHWs, doctors, and other stakeholders, family members, to try to understand, how it is that this may have been so effective. What were the active ingredients in the CHW intervention to not only increase use of medications, but to make them more effective, significantly more effective. So just to recap, we were delighted to see that a CHW was accepted by 2/3 of the people that it was offered to, and that it's significantly increased abstinence in this large, cohort of people with serious mental illness who smoked, to learn that it was mediated by increased provision of cessation medication, particularly varenicline. And so thinking of sort of where do we go from here, and it's to echo Marianne, it's to an implementation trial. So we implemented this in a community-based, standing system of care that was CVFS, and then it became ACCS. But really our next step is to go to a very large implementation trial. CHWs were hired into a job category that exists, right? Bachelor's level folks, we hired them into basically a psychiatric rehabilitation worker job category at that salary and with those hiring criteria. So we feel that this is something that can be taken out into the community. They built strong relationships and were effective. And so we've been invited to apply for an implementation trial in order to see if we can implement this intervention in a large system of care across a number of states. And we'll probably start in broader in Massachusetts in a phased implementation trial in the first sort of year and a half, and then hopefully with PCORI support, if we're fortunate enough to get that, we'll move to other states to see if this is something that can really help people. And as Commissioner Doyle said, increase the use of evidence-based treatment, evidence-based medical treatment that's integrated with people's psychiatric rehabilitation care. So I want to thank you all, and be happy for Q&A when the time comes. So I'll stop my share and go back to Mary Ann. Oh, wait. Oh, I wanted to do one more thing, if that's okay.
Go ahead.
I wanted to show our team. We had a fantastic team. Sally Ryring, who many of you will know, who's worked at Bay Cove and in the Department of Mental Health. Corey Cather, of course. Melissa Marovich, Dr. Marovich was the program director, and just a wonderful team here. And so feel free to send questions to me at this email address, and didn't want to forget that. Thank you so much.
Thank you, Dr. Eden. Sorry. We do have some questions from some of the folks who joined. Marianne, would you like me to read them out? Okay. So our first question is from Margaret Geyer, and she asks, I'm curious about how Dr. Eden understands the abstinence rate that seems to be much higher among those with treatment as usual who did not have AD, 15%, rather than the 6.8% for those who had AD.
That's a great question. Essentially, this is a cohort effect. So those who were eligible for detailing were, they tended to be perhaps less severe psychiatric symptoms. They were more likely to live in group homes, et cetera. So their abstinence rates overall were lower than those who in this smaller AD ineligible cohort who I think had less severe psychiatric illness.
And then Margaret Geyer also just wanted to make the comment, I really love that the relationship with the CHW seems to be the primary factor supporting change.
That's right. And I think that's absolutely right, Margaret. That's what we're seeing here, that the medications without all of that support and it did not move the needle, as you will, but the CHW plus the medication absolutely moved the needle. And these are abstinence rates that we'd be happy to see in people without the challenges of serious mental illness.
Thank you. Valeria Chambers has a comment and a question. She said, this is so impressive. And how many times a week were CHW available to participants?
That's a great question. That was really worked out in an interactive way between the CHW and the participant. They worked that out together. When they were trying to quit smoking actively, it might have been a few times a week, but sometimes people met once or twice or 3 times a week for months at a time. It really was between the two to try to work out what was useful, what was acceptable.
Great. And then Valeria had a second part to her question. Were the CHWs involved with additional aspects of care?
So they were not, and that's where this was not super real world. Their one job was to focus on basically smoking cessation, or if not smoking cessation, sort of medical health. I mean, but that said, they were given the latitude to work with patients on many things. So they might have given them rides to get groceries, or they might have given, certainly a lot gave them rides to medical appointments, whether or not they were associated with smoking cessation. One person wrote down that they went together with the person to get a library card. They often will have practiced some things that patients can use when they are trying to not smoke. So ways to distract themselves. They would play cards a bit, or they would do exercise. One even said they did a dance class together as just sort of getting ready to try to quit. And what are ways that you can fill your time that are healthy ways to spend your time, and also help you reduce craving, or just distract yourself from the desire to quit smoking until you've had that become the new normal or a new habit.
Great, thank you. Dr. Dan Breslin had a question. Did you have any measure of adherence to varenicline in the participants prescribed varenicline? I'm going to pronounce that horribly, I'm sorry.
That's okay, varenicline, I got it.
Without a CHW who had a lower abstinence rate?
Yeah, that's a great question, Dan. Thanks for the question. So these numbers around taking the medication are from an annual self-report. It's basically a 5-minute survey from participants. And so we don't have a measure of adherence. We have self-report, how much did you take? And we included somebody as taking the medication if they reported that they got a prescription and they took at least 1 dose. So that got you as taking the medicine. We've been working with Mass Health for a year or so now to get claims data so that we can look at fills and the second and third and fourth fills. So we'll hopefully we have faith that we will get those data and be able to look at that.
Thank you.
Great questions. Thank you, everybody.
Please feel free, if you have other questions, you can send them through the Q&A. Panelists, if you have questions, feel free to send them through the chat. And I don't know if we could open it up for questions about the centers themselves, if folks had questions about that for Dr. Davis and Dr. Cather.
So I'll say that we do have extra time. We have been very efficient with our presentations so far. So we do have some time if folks do still want to send in questions either for Dr. Evins or for Corey or myself about our centers. So we'll give a few moments for those to accumulate.
We have, so Dr. Dan Breslin just sent in a second question. Dr. Evins, what did you see in terms of adverse reactions to varenicline?
Yeah, there's basically no signal for adverse reactions to varenicline. Again, this was self-report annually. That was really between the patients and their doctors, but we did ask.
And Ken Farbstein wanted to know if Dr. Evins could please describe the type of education given to the CHWs.
Absolutely. So these are people who were not employed in the agencies at the time. So they had employment-related, hire-related training on working with people with serious mental illness, on confidentiality, et cetera. They had tobacco treatment specialists through the fabulous program at University of Massachusetts that Lori Piebert runs. And then they had education in the 10 core competencies required for CHW certification in the state of Massachusetts, which involves, professionalism, but also healthcare navigation, And then we also gave them the same education that we were bringing to providers. We gave them the academic detailing training, as well as the physical materials to bring with them when they happen to attend primary care doctor visits with participants.
Thank you. Jo Hang just wanted to say thank you, Dr. Evans.
Oh, thank you.
Okay, it looks like we probably have some extra minutes for a break, which is a nice thing to have. One more question I see.
One more question, Marianne. Go ahead, Dee.
Jo Hang is wondering, they say, I'm not sure if this is relevant, but I heard that nicotine could help with people with mental illness as well as Alzheimer's disease. Would you be able to provide information regarding this?
We actually did a lot of work on this back in the 90s, a long time ago. Nicotine and then also the medications used to help quit smoking, varenicline or nicotine patch, do improve concentration in the short term. And it specifically in people, it may help learning in people with schizophrenia. And this may be why it's really important for people with schizophrenia to quit smoking, to use one of these medications. You know, we just see that time and again, that with just behavioral treatment alone, people with serious mental illness are not successful for their efforts to quit smoking. But with a medication, and now it looks like with medication and some really good support, they can be quite successful.
And we have another question that came in. How did level of interest in tobacco cessation at the outset of the study affect the abstinence outcome? Did CHW involvement move people from lack of interest to interest in cessation?
I think it's really clear that that happened. We didn't collect data to test that specifically, although but we know from, so we didn't test that across the whole study, but we know amongst those who were assigned a CHW, there are quite a number who were not interested in quitting smoking initially, but after 4 or 5 months, they were able, with the help of their CHW, to identify the smoking cessation as a goal. So it definitely was a progression amongst a number of people. And, you know, we also encouraged people to try a medication, even if they thought they couldn't quit. And that's the new standard of care. And that really is something that I think hasn't gotten out there yet. And that moved people along too. So having a CHW to bring that information to the doctor and the patient, and to have the medication. So I think that both the CHW and the use of medication even before being necessarily ready to quit, that both of those actually move people along the continuum of being ready to try to quit. Sorry for the long answer. I hope that was clear.
Thank you. Dean Montier wanted to know, besides CHW, were peer specialists also included in this?
That's a great question. We tried to hire peer specialists to be CHWs and didn't succeed. We did have peers on our executive committee. So peers helped us in the planning and the execution of the study. We had peers and some family members on our executive committee. And we had people with lived experience come to every series of groups. So almost always we had somebody come the week before the quit date, somebody who had successfully quit smoking, usually in one of our programs, but not necessarily, who really could talk about how they did it, encourage people. That's been part of our program for, I don't know, 20 years. But in the implementation phase, I think it's super important. We were on a very tight timeline, and just, I think we got unlucky in trying to hire peers to be CHWs. You know, we had to hire 13 people within about 2 months. We did interview folks, but it just wasn't, we didn't find a great fit. But in the next phase, it's super important for us to implement peers in the various roles, either the full CHW role or components of it. Thanks for reminding me. I meant to talk about that.
Thank you, everyone.